Zaragoza Solutex chair, speakers, attendants, students, ladies and gentlemen. First, I would like to thank all of you for attending this meeting that has been organized by the Ramón Areces Foundation in close collaboration with the University of Zaragoza Solutex chair. I also wish to convey the thanks of people from the Ramón Areces Foundation, to which I belong as scientific advisor. The Ramón Areces Foundation was established in 1976 by Ramón Areces, a Spanish entrepreneur that, after raising the general store of Corte Inglés, decided to establish this foundation because his aim was, and these were his words, actually, I am quoting him, to give society some of which it has given in advance. Thus, the revenues of the new institution are devoted to the promotion of science in Spain. The aim of the philosophy, Isidoro Álvarez and his daughters, Marta and Cristina, have to pursue Ramón Areces' goal by furthering Spanish science through different activities. Among these activities, I like to stress three. Being one of them, that the Ramón Areces Foundation supports grants for doing research in different fields. In this context, the Ramón Areces Foundation has devoted during the last 10 years more than 2 million euros per year to promote the study of molecular etiology and treatment of diseases. Last call include the study of the infectious disease, cancer, rare and neurodegenerative disorder, and prevention topics. Of course, Ramón Areces Foundation does not forget other topics, especially relevant to oil, such as food technology, the climate change, new material, etc. Secondly, the Ramón Areces Foundation has a strong determination in helping young Spaniards in starting out the scientific careers. To accomplish this, the Foundation supports a scholarship for postdoctoral study abroad. This allows our students to engage in postdoctoral visits at the laboratory of the main research institutions in Europe, United States, Canada, Japan, and so on. A clear example, more than 700 scholarships have been given in the last 35 years. And thirdly, to promote the change with scientific throughout the world, the Ramón Areces Foundation helps to organize symposiums like this one in order to gather together experts interested in the same field and to allow a forum in which to exchange ideas fruitfully. In this case, this symposium framed the special interest that Ramón Areces Foundation has in those sciences that can directly improve our knowledge in the etiology of some important diseases and hopefully design new pharmacology approach. In fact, the result of this symposium can change the way to envision how to fight this disease, which are elusive to modern treatments. Finally, I would like to deeply thank all of you again for attending this meeting and to collaborate with us because your collaboration contributes in order for the Ramón Areces Foundation to fulfill its goal, particularly those related with the promotion of the science in Spain. Thank you very much. And now I give the floor to the Chancellor of the University of Zaragoza, who had given some words.
Good afternoon. I can see that we have a system of translation, so in order to justify the use of this system, because I feel more comfortable in Spanish than in English, I will move to speak in Spanish.
Good afternoon. I'm the Chancellor of the University of Zaragoza and Director of the chair Solutex. Already 5 years ago, together with Professor Medina, we inaugurated in the Aula Magna of the central building of our university the first meeting in order to start talking about science of resolution of this. Today we meet again some of the people who were there, and now in the fantastic environment of the Fundación Ramón Areces. Thank you for hosting this meeting in this venue. We've got Professor Serhan, of course, and we have people who have been already there in Zaragoza. Dr. Deepak Panigrahi, my colleague from the university, Dr. Angel Lanas, who also was there at that meeting as well in the auditorium, and he has traveled with me, and other people who were there that day. Dr. Hilur Nastidottir from the Karolinska can't be here with us today because since that day she sadly died. I'm not a physician. I'm a chemist, and my role here is in this chair is to improve the methods of preparing the lipidic molecules that you then are going to use, make them more sustainable, and use the subproducts as well, because our group is working in sustainable chemistry and in circular economy, and also, incidentally, in controlled release of the drugs. This is something that we do as for fun with some colleagues from the Hospital Miguel Servet. What we'll try to see here today are the new advances in this type of resolution. And we will also see, for instance, the study from Dr. Vergiev, Joseph Vergiev, José Vergés, so that give him the floor so that we can start with the next session. Good afternoon to all of you for being here. We are all very happy. It's a great honor for me to be here as the moderator. Let's hope that at the end everything will turn out all right. The panel and the topic deserve it. I also would like to thank the organizers and the organization through Don José María Medina, Vice Chairman of the Areces Foundation, José Antonio Mayoral, Chancellor of the University of Zaragoza, that thank them for us being able to be here. We have a very interesting topic before us. The agenda that we are going to use first, we will have the 4 talks. The first one from Professor Charles Nicholas Serhan. Then the second talk by Bruce David Levy, Dr. Bruce David Levy. Online, we will have Dr. Jan Schwab, who was unable to come due to the snow. He couldn't leave from the airport, but he's going to be online with us. And Dr. Deepak Panigrahi, who is also make his presentation. And at the end, I also will make a short presentation, 10 minutes presentation on our experience with the SPMs in the area of arthritis. So we will have the lectures, and at the end there is a turn for questions and debate. Those of you who want to ask questions, you have to wait until the end. If somebody has to leave, you can write it down, but the debate will be held at the end. So it's a very interesting topic. I'm a family doctor, and then I made the specialty of internal medicine and clinical pharmacology in Canada. I'm clinical pharmacologist, and the issue of inflammation is something that with the master, Dr. Russi, I learned very much working on inflammation. And more specifically, this whole issue is a very new and interesting topic for me as well. And I would say that now we have the best international people in this field. We are very happy that the whole field from Harvard is here with us, the whole team. Thank you very much for being here with us. The first speaker, Professor Charles Nicholas Serhan. I'm going to read just 4 lines.
We can speak a lot about from you, because you have a very incredible curriculum vitae, no? El doctor Serhan, here I think have in English and in Spanish. Professor Serhan studied how the body tissues. He discovered specialized resulting mediators, SPMs, like resolvins, protectins, medicines derived from omega-3 fatty acids. These molecules stop excessive inflammation and promote healing without weakening the immune system. Serhan is also the president of the Scientific Committee of Solutex, a company specialized in lipid-based solutions. His research focusing on the mechanisms of potential treatments for chronic inflammatory disease, opening new doors for therapies targeting inflammation resolutions. We can speak a lot about you because you have thousands of publications, no? But you know, we are happy to stay here in Madrid. And please go ahead when you want to make your explanation and your speech. Thank you very much.
Okay, thank you very much. Muchas gracias.
A pleasure.
Hola. Thank you so much for the honor of being here today with my colleagues. And I hope to convince you of why I remain fascinated and excited about the topic today of controlling inflammation through understanding of the molecular mechanisms in resolution. I want to thank the Foundation for the opportunity to bring our work to you today, and I want to thank Dr. Marino for enabling this to happen. My institution, Harvard Medical School, requires that I show you this slide. As you can see, I have no conflict of interest. Our group has been amply supported over the years by the NIH, which supported this work. And today, I serve on scientific advisory boards listed here just to watch how our babies are developing. So we're going to be focusing on mediators and pathways that play a role in the resolution of inflammation. So my colleagues know that I respect the intellectual origins of the scientific question. So this is our friend today. This is Celsius, and this is from the University Library in Rome. This is Celsius's original manuscript, and he defined for us the cardinal signs of inflammation, tumor, rubor, calor, and dolor. But the real question that we arrived with was best capsulated by Rob Flower, introduction to a presentation I gave in London. And it says, who will guard the guards themselves? Okay, so this is a familiar triad. The cardinal signs of inflammation. This is the presentation of the pathologic features that are common to many diseases. I, as a young scientist, was very fortunate to learn from these three scholars, Suni Bergstrom, Bengt Samuelson, Sir John Vane, who received the Nobel Prize in 1982, Physiology of Medicine. And I was very fortunate to be a young fellow in Bengt Samuelson's lab at the time, so I got a chance to go to the Nobel. And they received the Nobel for the structural elucidation of the prostaglandins. And Sir John for discovery that the non-steroidal anti-inflammatory drugs block the formation of prostaglandins and thromboxanes. Today, I want to emphasize that all these diseases listed here have inflammation as part of the pathobiology. But I want to emphasize that it is excessive and uncontrolled. So we want to think about the control mechanisms. And our interest in inflammation anteceded the popularity of inflammation. Inflammation is in the news nearly every day. And this is from the Washington Post. And this professor in psychiatry makes this statement. He says, the inflammation is killing us. And one of the ways that it kills us is by affecting the brain. We were also featured on the cover, my laboratory and my colleagues, for our work on anti-inflammation. In this article, the entire special issue of National Geographic was devoted to inflammation, and we enter the picture of how we can end inflammation. Okay, so if we can all agree that inflammation is the heart of the problem and the basis of obesity, diabetes, exacerbation of pulmonary diseases, chronic stress in our lifestyle. But inflammation is not a bad guy. We have to start thinking about inflammaging and the impact of the pro-inflammatory diet. So I ask my group, each lab meeting, can we help? Can we help? Our mission is to help as many people as possible in our research, and these are the pictures of inflammation that we're all aware of. We are driven by the inadequacies of the current pharmacopoeia, the ways of treating inflammation today. There are too many unwanted side effects of the current anti-inflammatories. So today's presentation, I will give you a high-level overview of the key concepts in the resolution phase, the mediators of inflammation, how we worked out the structure of the resolvins, the protectins, the merisins, which are known today as the specialized pro-resolving mediators. And I will give you two examples of why I remain so excited about the field that demonstrate the power of what the SPMs can do. Okay, so I wanted to get a picture here that speaks to you. We're really interested in the body's first response to an invader. And that first response, that first ringing of the doorbell, is the acute inflammatory response. Not acute inflammation, the acute inflammatory response. This is a physiologic response that we mount. And I would like you to go home and think about this as, oh, they're talking about resilience, how to build our resilience to live longer and healthy. So, being a professore, I have to come with today's learning objectives. Some of the terms for today, in the acute inflammatory response, I thought this simple equation would be meaningful for you. So resolution of inflammation is a function of, well, think of this as the first derivative, of leukocytic infiltration. And then there is the lipid-mediated class switch, was a big surprise for us. And the resolvins are produced and the other SPMs, and their principal job is to reduce the cytokines and increase efferocytosis. So those are all the terms we need to know today to reduce pain and return to homeostasis. So resolution equals the function of the resolution interval to the power of the SPMs. Okay, so if we look in the pathology textbook, which I happen to do quite often, we thought that this looked like a decision path to go to chronicity or to resolution. The acute response is protective from invaders, and all those chemical mediators, the prostaglandins, the leukotrienes, the chemokines, are positioned to tell white blood cells to leave the vasculature, the postcapillary venules, to protect us. Now, the acute inflammatory response can go to chronicity and chronic diseases, to organ fibrosis, to abscess formation. The example that I'm going to end on is the inflammation in the periodontium that leads to barrier destruction and the eventual loss of the tooth. This is a chronic health concern in the United States. And it is a very, very good example of leukocyte-mediated tissue damage. So when the white blood cells, the neutrophils, come to protect us, they inadvertently can spill their armamentarium that's designed to kill bacteria. It could actually lead to bone destruction. And this is a very similar pathology to arthritis. And that's why we chose it. So, in the textbook, The response to resolution was thought to be an passive process, meaning what? Meaning that all those chemical mediators that were made to bring the white cells in would just dilute, and that dilution would make the cells stop coming. This is not the case, and I will show you data to indicate that it is an active biosynthetic process that results in the formation of the resolvins in a whole superfamily of molecules. We need many of these molecules to take care of the job. So, back to our textbook of pathology. What is resolution? Well, pathologists knew what resolution was. They could see it under the microscope. And here you see the tissue and the infiltration of the tissue with leukocytes. So, when I was in school and studied pathology, it was Robinson-Cotran's second edition, 1979, and this is all resolution looked like. This is the blood, and here are the leukocytes, and importantly, when the leukocytes, the neutrophils die, leaving apoptotic cells and debris, macrophages come along and eat them. This process is very well studied. It was edema made in seconds, neutrophilic infiltration, and then they go away, and then there's a non-phlogistic, non-fever-causing recruitment of mononuclear cells and macrophages to bring us back to homeostasis. But we ask very fundamental questions. What are the molecular mechanisms in resolving exudate? Exudate is pus. What's the molecular mechanism? Are there specific mediators? Well, there are. That's why I'm here today. So we did a very simple experiment. We made the air pouch on the back of the mouse. Why? Because in the 1950s, and to test non-steroidals that were in development, experimentalists used this model to emulate the synovium, the knee, to test the properties of new non-steroidals. Well, we thought that this is a good place to start, and we did temporal and differential analysis. Leukocytes swarm in here. They move in along a chemotactic gradient like sharks smelling red blood cells. And we did the modern techniques, lipidomics, proteomics, CyTOF, cytokine arrays, transcriptomics, more recently, in this scenario, and that's how, from pus, the resolvins were born. So here's an example, an illustration of what we do in the lab. We do solid phase extraction and then mass spectrometry. And we made libraries of all the known mediators at the time. And when we found new compounds, novel compounds that were bioactive, we did the structural elucidation and then retrograde analysis and total organic synthesis so we could confirm the function. And these were the bioassays that we looked for function. Well, resolution in the textbook was defined as cessation of leukocytic infiltration. So we had an assay to study neutrophils transmigrating over epithelial cells, and on the other side, efferocytosis, which is the clearance of apoptotic PMN that is stimulated by the SPMs. And then we learned later, much later, that this extended to bacteria and microbes, that the SPMs stimulate the clearance and killing of microbes. So this is resolution, and this even extends to fibrin clots. We introduced quantitative indices so that we could quantitate these events as they occur in experimental models. So this is what we learned. The ideal outcome is complete resolution and protection. Here are the definitions I just told you. Here is the edema. But when the neutrophils reach the max, when Dr. Levy was a fellow in the lab, we discovered the lipid-mediated class switch, and then all the birth of the SPMs to carry us to homeostasis. We spent time elucidating 4 different pathways, molecule by molecule, and this is a dissection of an air pouch so you can see. And here are the SPMs. So they are known in the literature probably best as stop signals, and since the discovery of the first resolvin, there have been many additions of other molecules, proteins, and gases that can help to stimulate resolution. So we were very encouraged very early on, because this is my finger, for full disclosure, and we bleed for our experiments, and we could assay the chemotaxis of neutrophils, and you can see here that in a cytokine gradient, they assume this morphology of crawling, but when they're exposed to resolvin D1, they round up and they stop moving. Okay, so we were able to do the pharmacology, and here you can see the cells chemotaxing with DHA, the precursor, having no impact on the movement. At the same concentration, resolvin D1 stops those cells. So this told us very clearly that DHA, the omega-3s, needed to be converted. So this is from the very first elucidation of resolvin E1. This is the LC chromatogram, and this is the basic mass spec of what we called later resolvin E1. And we worked out the biosynthesis, and the point I want to make is that this is a collaboration between the endothelial cell of the vasculature and the neutrophil to make resolvin E1, which stops more neutrophils from coming in. And here is an intravital picture. This is the postcapillary venial. These shiny little balls are the neutrophils sticking and rolling as they do in the vasculature. But when you add resolvin E1 in this experiment, you can see that the neutrophils disengage. And the mechanism is the downregulation of the adhesion molecules CD11, CD18, for example. So this is a scanning EM from in vivo, and this is how we see the picture of the endothelium and the platelets. This is the leukocyte. The go signal is leukotriene B4, stimulating chemotaxis. The stop signal are the SPMs. And so what we see is happening is that the omega-3, EPA, and DHA are converted to 17-HDHA and 18-EPA, which is then picked up by the leukocyte to make the resolvins. So you want to think about the resolvins as little traffic cops, little robots controlling the traffic. And that traffic is very important to the outcome. So when we look a little deeper, this is the cyclooxygenase 2 that was discovered. This is a second enzyme that has a wider catalytic center, and this is found in the vascular endothelium, and EPA and DHA fit in here very nicely. When we take low-dose aspirin, the enzyme's activity is blocked, no prostaglandin production, but big surprise, and the fellow I did the first experiment with is actually here today. There's a Fulbright scholar from Spain, from Barcelona, today Professor Jean Claria, and I can tell you we cried over this experiment. But we learned later that the low-dose aspirin actually produced each family of the SPMs in R configuration rather than S. The R configuration is the aspirin-triggered version, and the bottom line is that they are longer acting. So think about this. Aspirin jump starts, resolution, and I have to say they were born in Boston. This is the cartoon picture of how it's envisioned. This is the LC chromatogram of human plasma, and you can see that resolvin E1 peak is very small. If you do, at that time, traditional MS-MS, but we did MS to the third, and you could see that small peak becomes this nice big peak, and that made us very happy. So our next job was to confirm the biological function, and we wanted to do that through total organic synthesis, and this enabled us to assign the complete stereochemistry, and here's the bottom line. This is the blockage of the leukocyte traffic, the precursor, little activity, resolvin E1 made biologically, about 50% inhibition, the total organic synthetic resolvin E1, nice match, and you need log orders higher of dexamethasone to get to that level of reduction. So resolvin E1 reduces leukocyte traffic to the air pouch, and as I said, you need 10 micrograms per mouse of dexamethasone to get to 50% inhibition, where you only need nanograms, log orders lower of resolvin to get there. Well, this was the identification of resolvin E1 in a population study was completed this past year by a group in Australia. They looked at 978 subjects, 27-year-old Australians, healthy, and they found that increased resolvin E1 correlated with low BMI. So that was very gratifying for us to see. We continue to work on the biosynthetic pathway, which is illustrated here, and then we learned that there is, in addition to resolvin E1, there's resolvin E2, and determined its structure, and then Resolvin E3, and then most recently, I should say that Resolvin E3 was born in Japan by a former fellow, Makoto Arita, and then we discovered that hypoxia stimulates Resolvin E4 production that has the job of clearing senescent age red blood cells. Okay, so this, I want to point out, is a very exciting publication showing that clinical doses of EPA supplementation in patients with major depressive disorder is associated with high plasma concentrations of the E-series SPM. So this is an important clue of the future. And this is really mediated by reduction of neural inflammation. So this is the picture as it stands today. We systematically worked out how endothelial cells under hypoxic conditions interact with leukocytes to produce the D-series resolvins, the E-series resolvins, and then we discovered protectins, a whole family of molecules formed from this intermediate, 17-hydroperoxy. The most notable of this family is neuroprotectin D1. And then late in the game, when the macrophages come in, they start producing the macrophage-derived mediators of resolution we call the merisins. And they have these functions, which are really the pro-resolving functions: clearance of apoptotic cells, counter-regulation of the cytokine storm and the eicosanoid storm, and all leading to reduction in pain. Okay. So this is, in my view, an entire metabolic network that's orchestrated through transcellular biosynthesis, cells talking to each other. And this is what the cartoon looks like. We start here. This is to remind you that the current non-steroidals act on the prostaglandins, which are needed to kick off. You need the prostaglandins to start the lipid-mediated class switch, and then to progress on to resolution with the SPMs. So, non-steroidals blocking prostaglandins, is that really a good thing? We worked out the circuit. It's prostaglandin E2 drives up lipoxins and SPMs, and it turns down via cyclic AMP the leukotrienes. Now, this picture is René Descartes, picture of the vasculature post-mortem. But it's there to remind me to tell you that resolution begins in the activation of the vasculature. And we liked that picture so much, we were able to get it on the cover of our article that came out in this journal. Okay, so now, today, we have set up an automated system for tandem mass spectrometry targeting the pro-inflammatory lipid mediators and the pro-resolving mediators, all driven towards being able to do principal component and cluster analysis. And it brought the idea to us that we could focus on precision therapeutics, personal therapeutics, and precision nutrition. Those are the take-home messages today. This method that we introduced is used now around the world, and here's one that I like very much from Martin Hirschberger's group, where he looked at human adolescents and established the values of the SPMs in children and showed very clearly how those values increase with giving supplementation. Systematically, we went around the body, and I'll just make note, and we and many other groups around the world We found the SPMs in tears. With Dr. Levy, we found exhale breath condensates early on. Breast milk was a big surprise to contain SPMs. And I want to draw your attention to the placenta. Work from the Australians. The placenta is a powerhouse of producing SPMs. So, being curious scientists, we had to look around the animal kingdom, and we found that invertebrates produce SPMs, and all the way up to humans, baboons, rats, but the big surprise was fish. Rainbow trout, anchovies produce resolvins and the SPMs, and that is key to our relationship with Dr. Marino. There's so much to be done. And just recently this summer, we discovered in human saliva a special resolvin. It's the 17R version of resolvin D2, and we were able to do that using a new high-sensitivity mass spectrometry technique shown here, making a derivative of the molecule. But this is really something I'd like you to think about. The centerpiece here is yeast. The neutrophils, human neutrophils, are moving in on a chemotactic gradient that's computationally illustrated here as the blue sphere. And this is in a microfluidic device that was designed and engineered by our colleague, Daniel Arimia. And it very nicely illustrates the swarming, and there's a reason why I'm showing you this, and that'll come up soon, how white cells swarm to protect us from invaders. Okay, so if you put into that microfluidic device an SPM, it stops the swarm. That's the key. And on the other side of the equation are the macrophages shown here, eating apoptotic cell debris. And on the right of the slide is the 3D version of that data. So here you have one molecule, one resolvin. They all do the same. Stop signal for neutrophil, but a go signal for, they are agonists for macrophages and mononuclear cells. So we went on and looked at them in various animal models. In vivo, for example, resolvin D2 proved to be very potent in the picogram amounts per mouse. They also stimulate the production from endothelial cells of NO without immune suppression, and actually brought about a change in thinking about stimulating host-directed therapies to help clear infections together with bacteria. Okay, that's nicely illustrated in this New England Journal article that was written by a colleague from NIH discussing one of our papers, but here's that picture of the endothelial cell talking to the leukocyte, the neutrophil, to enable the clearance and killing of the bacteria. Okay, so what cell types are making SPMs? Well, apoptotic PMN make SPMs. The interaction of PMNs with endothelial cells, and right down the list, the M2 macrophage produces, this is the reparative macrophage, it produces the lion's share of SPMs. But there have been more discoveries, which is quite surprising, that muscle makes SPMs, and so does adipose, and you can talk to Professor Claria about that. And then we found that the vagus nerve on electrical stimulation produces SPMs. Very exciting. So here's some of that illustrating, but what I want to emphasize is that the function of the resolvins and the SPMs is on the stem cell, both in the muscle and in the periodontium, and this brings about the notion that SPMs stimulate regenerative repair. Okay, so here's an example of the indices. So here is resolution going back to baseline. That green is the neutrophils, and the red is non-resolving inflammation. The key point here is I want you to go home and tell your family that time 0, we can treat and bring down the magnitude of the inflammatory response. But what we found is that non-steroidals disrupt resolution, COX-2 inhibitors disrupt resolution, lipoxygenase inhibitors disrupt resolution, lidocaine, and we found more recently that environmental agents can disrupt resolution, and this has been demonstrated in humans. So we have a lot to learn about the world and how it impacts the body's resolution response. Okay, where am I? Next slide. Oh, I just wanted to show you that this was shown in humans. This is from Markworth's study. You can see resolvin D1 production here, and then they gave ibuprofen, and look what happens. Ibuprofen reduces the production of resolvins, and this is in healthy subjects. So resolvins have been shown to act in many translational, potential important scenarios: organ protection, host defense, pain. And it's not that the resolvins can do everything. Cancer, it is that they are controlling inflammation, which plays a role in all these responses. So Dr. Panagrahi is going to show you this, but I couldn't resist showing you how the resolvins reduce the size of the tumor down to this barely, and this is from our first publication together, and he will go into great detail on this. Very exciting work on how resolvins can reduce tumor burden. And they do that by shortening the resolution interval, turning down the cytokine and eicosanoid storms, regulating histamine, edema. They are not immunosuppressive, and in many cases, they turn on IL-10. We systematically identified these receptors shown here, which have nanomolar KDs, and we qualified them with transgenic and knockout mice, each receptor, and then Ruranji's lab identified this as the PD-1 receptor. And I want to make the point that they do not signal calcium. Calcium is a go signal. Using CyTOF, we demonstrated that they signal through a cascade of phosphorylation. This is in human whole blood, and this experiment was performed by Dr. Librarios when she was in the group, and you can see very nicely this phosphorylation cascade. We've been studying, using molecular modeling, how the resolvins interact with these GPCR receptors and calculating the frequency of the on time. The other interesting thing that these receptors do is they turn on microRNA networks. So they have short-range actions on leukocytes, but they have long-range actions that last for weeks in these various networks that, if you're interested, you can find in our papers in the literature. Okay, so to keep on time, how do they work in pain? Well, this is from our first paper on pain. Here's morphine with Ruron G in his group. Here's Resolvin E1. It's log orders more potent. The key to this is regulation by the receptors, and they are working on trip channels, which are important in regulating pain. And you could nicely see in this table that DHA and EPA don't really regulate the channel at meaningful concentrations, but resolvins do in these IC50 in the sub-nanomolar range. So this is a very clear example of the precision of the resolvins in regulating pain. And then I'm obligated to show you this exciting result from a group in the UK where they found that the precursor to the D-series aspirin-triggered resolvins, 17R-DHA, is very potent in reducing arthritic pain in this model. It's log orders more potent than dexamethasone or morphine. And that it gets extended on into neural inflammation, as I alluded to, cognitive decline, Alzheimer's disease, and more recently we identified SPMs in cerebral spinal fluid, and then this exciting work from the Japanese telling us that Resolvin E1 and E2 may be endogenous antidepressants. Dramatic impact on the vasculature and on the heart. This is from a review from a group in Canada, and it's stimulated by our work with Ganesh Haldane here on how Resolvin D1 resolves inflammation in the vasculature, and our earlier work with vascular surgeon Michael Conti, showing that Resolvin D1 reduces intimal thickening. This is very, very important for vascular medicine. And now we know today from the work of Paul Ritger and Peter Libby and colleagues at our hospital that inflammation in cardiovascular disease is an important, if not more important than cholesterol, as a predictor. So Resolvin D1 does all these magnificent cellular functions. We worked out the biosynthesis completely shown here. You might say, oh, but Charlie, that's so complicated. Does that really happen in humans? Yes, here's a study from a group on the West Coast, Mohit Jain and colleagues, and they report in 510 patients. You'll see in the volcano plot here, after exercise, there's Resolvin D1. Okay, so think about this. If we block the resolution response, what happens? Well, we don't get to full healing. We can go to fibrosis, cellular senescence, chronic inflammation. So think about building the biosynthetic capacity for resistance and resilience. Resilience. All these drugs are ones you want to keep your loved ones away from. And all these diseases we've worked on with my colleagues over the years, from atherosclerosis to periodontal disease, and we see, of course, a dysregulation of the lipid mediators. and the concept of failed resolution occurs, and likely this occurs in aging as well, and any of these factors can be relevant. Low substrate, impaired biosynthesis, lack of a receptor for a resolvin, potential genetic defects in making the enzymes. So COVID taught us from many publications, from other groups, that the lipid mediators are dysregulated in COVID. And it may be as simple as low SPMs being associated with poor outcomes. Okay, so this brings me to the example I want to show you. This is my colleague, Daniel Kressler, at Washington University. This is human data on human lung transplants. He's a transplant surgeon. These are the levels of resolvins in transplanted lung. The clinical problem is the clinical syndrome, primary graft dysfunction. Okay? So then, here's the hard data carried out in my lab on the identification of each of the resolvins in the human lung, and following reperfusion, that's blood re-entering the organ, we found, surprisingly, nanomolar amounts of resolvins being produced. Well, this told us that we had to dig deeper. What do those resolvins do? We turned to intravital microscopy. The green are the leukocytes swarming in, and here you see the time course in the mouse of the different lipid mediators that are produced. The bottom line is that resolvin D1 comes up within 3 hours. So that told us we needed to add resolvins back into the system. And when we did that, it prevented the leukocytic damage of the lung. And that's nicely illustrated here in this movie. The green are the neutrophils swarming into the transplanted lung, and here is the great reduction of that leukocytic swarm and collateral tissue damage that occurs as a result of pathologic swarming. And if you want to see those movies up close, it's in this PNAS paper. And we did RNA-seq on 11 populations of cells in the transplanted lung. The bottom line is that resolvin D1 turns on genes and pathways that regulate chemokines and cytokines and turns it down, and it protects the lung. So you get lung protection from, and you can think about that in any organ. You can think about it in your brain, you can think about it happening in your knees, you can think about it happening when you're aging. So what happens, Charlie, when you have a distal infection? What happens in the bone marrow? So we addressed this question recently, and the bottom line is that during resolution, as illustrated here, in the resolution phase, there is a clear regulation of the granulocyte precursors in the bone marrow. And we took a multi-omics approach to interrogating the bone marrow, and what we learned here, the bottom line, is that resolvin D4 was playing a very different role than the other resolvins. Leukotriene B4 is that go signal for deployment of emergency granular poiesis. This happens when you first get that invasion, and resolvin D4 disengages that. So it slows down excessive leukocytic recruitment, diapedesis. That's illustrated here. And this is something that I'm constantly reminded of, that alpha signals omega. And you probably see this every time you go to Mass. Okay, so there are clearly effects on the innate immune system, illustrated here, neutrophils, macrophages, but then we learned that there's effects of the resolvins and SPMs on the adaptive response, turning down chemokine and cytokine production. But the most exciting and the future lies in this illustration of our work on electrical vagus stimulation, where we see that electrical stimulation of the vagus makes the SPMs. So in closing, this is where we want to be. The SPMs cause the lipid-mediated class switch to take us to complete resolution. We want SPM-based therapeutics to prevent chronic inflammation. Simply put, anti-inflammatory drugs block us and become immunosuppressive, and pro-resolution, stimulating the body's response to resolve. Well, we did this in 2 trials, first in the eye, in dry eye disease, 232 patients treated with Resolvin E1 mimetic, reducing inflammation, and then with my colleagues at the Foresight, we obtained funding from NIH to do a 28-day trial of 127 patients for the periodontal disease, for collateral tissue damage. Here are the results. 28 days, 127 patients, reduced inflammation. But the big surprise, as always in a human clinical trial, this mimetic turned on SPM production in peripheral blood of the patients treated. A clear example of the feed-forward mechanism. So this is the take-home message. SPMs limit the magnitude and the duration of the acute inflammatory response to protect organs and stimulate stem cells for tissue repair and regeneration. Think about precision therapeutics, precision nutrition. I want to make this point that many of the fish oils are not equivalent to the molecules that we're talking about, pure molecules, EPA and DHA in the body to make SPMs. Many of the marine preparations of oils contain a lot of other substances, such as fish steroids. This is the summary of the take-home, and I'll just leave you with the SPMs where we started are guardians of tissue homeostasis. And I must thank my many colleagues over the years and the members of my group, and most importantly, the funding from the National Institutes of General Medicine. And I want to thank you.
Well, thank you very much, Professor Serhan, for your nice speech, elegant presentation, you know, and a lot of work must done in your lab for years, no? To present this data. Huh? Congratulations. Thank you very much. Questions, I mentioned before, will be done later in the end of the meeting. Now we have the second speech. Is Dr. Bruce David Levy. He's the medical director from Harvard University. The presentation, the name is Resolving SPMs in Pulmonary Medicine. You know, the same that Professor Serhan, you know, he has a very impressive CV. We can make a summary resume. Is that Bruce Levy, the Dr. Bruce Levy, investigate the mechanism of lungs inflammatory and repair, focusing on disease like asthma, chronic obstructive pulmonary disease, and acute respiratory distress syndrome. His research explores specialized pro-resolving mediators, SPMs, which help resolve inflammation and promote tissue recovery. He studies how these mediators can be used to control excessive immunoresponse in the lungs. Levy's work aims to develop new therapies for lung diseases by enhancing natural resolution pathways. His findings contribute to better understanding and treatment of chronic and acute respiratory conditions. Okay, thank you very much. You can start as much as you want. Thank you.
Thank you for the nice introduction. Well, thank you, colleagues. Buenas tardes. It's wonderful to be here. I'd like to start by thanking the Foundation for bringing us to lovely Madrid. We've been so fortunate to escape the snow and cold and wind of Boston to enjoy this lovely weather here in the city. And thank you for taking time out of your day to be here with us. I also want to start by thanking Charlie for a wonderful introduction and for all of the work and all the inspiration in the field. I started my career in Charlie's lab as a clinician, an early trainee, wondering whether scientific pursuits would be part of my professional activities. And I was incredibly inspired in the lab, and over the course of my career, what's happened is Charlie, of course, being generous to the field, as you've heard, has been personally generous, as now the mentee has become a colleague, and we're able to collaborate as professional colleagues and enjoy that immensely. So thank you, Charlie, very much. All right, so I'd like to talk to you about specialized pro-resolving mediators in respiratory diseases, and so we'll focus in on that topic for the next several minutes. I do have a few disclosures as well that I've listed here related to some equity interests, some consulting work, and some grants we've received. None of these are particularly germane to today's topic, but I disclose them for your information nonetheless. Okay, so SPMs, specialized pro-resolving mediators in respiratory diseases. This is an image from a review that Charlie and I just recently did in the annual reviews of physiology and medicine. And it highlights in one slide this broad topic. And I refer you to this review if you're interested in further reading on the subject. So it emphasizes roles for resolvins and the SPM superfamily and their impact in terms of leukocytic function in pro-resolving mechanisms as it relates to inflammation, infection, tissue injury. And it also looks at functions related to reducing neutrophil infiltration, as you've just heard eloquently described, and this notion of collateral tissue damage, innocent bystander tissue. This is especially important in the lung, where the alveolar structure is so fragile and can be easily damaged by excessive leukocyte activation. So this is now quite a robust field, and so you can see I'm highlighting lung infections, asthma, all the COVID-19 related activities, cystic fibrosis, and acute lung injury and ARDS. And then here are some of the most active molecules we've seen in the lungs from the SPM family. For the sake of our time together, what I'd like to do is focus in on a couple of these indications in particular, asthma, and I'm going to focus in on respiratory virus infection in my comments. So this was in the New England Journal of Medicine from Denmark, from the COPSIC trial. And this was really impactful. This is a large number of mothers who were supplemented in the 3rd trimester of their pregnancy. And then the kids were followed for over 6 years after that. And what the authors found, the investigators found, is that supplementation with N3 long-chain polyunsaturated fatty acids in the 3rd trimester of pregnancy reduced the absolute risk of persistent wheeze or asthma and respiratory viral infections in the lower respiratory tract of the offspring by approximately 7 percentage points. That's an absolute reduction. That represents about a 1/3 reduction in the health of the babies. Very impactful study. And this was written up by an author who is not part of our direct kind of team as a perspective on the importance of this trial. And you can see in the red here on the left, conditions of inflammation and bronchoconstriction. And this is the arachidonate pathway to the leukotrienes. And in blue, fish oil-induced resolution of inflammation and bronchoconstriction. And here's the DHA and EPA pathways to resolvins and protectants. And so this perspective highlighted the impact of the fish oils as promoting SPM production as part of the benefit seen in the clinical trial. So if we're going to talk about asthma, we have to come together as a definition about asthma. So asthma is a chronic inflammatory disease of the bronchial tubes in which the airways constrict too much and too easily to a variety of environmental stimuli. It's a very prevalent disease with a substantial disease burden. It affects all races and ethnicities. It's estimated that 8% of American adults and 10% of American children have current or lifetime risk of asthma. It's globally predominant, with over 300 million individuals afflicted with asthma. It affects infancy to old age. Before puberty, boys more than girls. After puberty, women more than men. And there have been significant increases, of course, in prevalence over the past few decades. In Spain, since we're here, 5.7% of children under the age of 14 have asthma, and over 11% have allergies, mainly allergic rhinitis. So if you bear in mind that around 6 million people under the age of 14 live in Spain, the data would indicate that there's nearly 800,000 children with some type of allergy and nearly 400,000 with asthma, a substantial burden. And even more shockingly and terrible is that in the global asthma report from 2 years ago, it was found in Spain that asthma kills as many people as traffic accidents in Spain. This is a very morbid condition, but also can be mortal. So that emphasizes the importance of studying this, and the key features of asthma symptoms result from some combination of airway smooth muscle constriction and bronchial inflammation, and the patient experiences this as cough, dyspnea, chest tightness, or wheeze. That was the illustration. Here is a slide of sadness. This is from an autopsy of a young woman who died with status asthmaticus, but it illustrates the pathology extremely well as we see that round opening that you'd expect as a tube of the airway is nearly completely closed. You try to use my pointer here. Okay, so in the middle here is a mucus plug, just a plug of mucus blocking the airway. The round cylindrical airway is now crenellated. You can see with all the folds with epithelial cells that are bursting with mucus cell metaplasia. All of the leukocytes surrounding the area, that's the tissue inflammation that we see. And then in the red, circumferentially around the airway is smooth muscle that is too big and contracting too strongly. That's the pathology of asthma. So is asthma, severe asthma, a resolution failure? So also in this review in the annals, this is a slide that Charlie just showed you, but I just will briefly review. Here's the pro-resolving ligands that we've been talking about, the receptors, and the nanomolar, the low nanomolar receptor binding affinity of these SPMs. And then their target cell types, and it's not a uniform thing. There are some cells that express one of these receptors more than the other, and vice versa. And so we see that enables these molecules to have cell type specific actions. And the concentration ranges, as Charlie emphasized, are in the low nanomolar range, or even picomolar in some respects, if you look at the cellular phenotype of macrophage phagocytosis, macrophages eating things, bacteria, dead cells, debris, etc. And this field has all been bolstered by experimental techniques to silence RNA, to knock out and generate transgenic mice. So I'm going to tell you a few vignettes that I think are relevant to the asthmatic airway that relate to SPMs. One on airway smooth muscle, one on the airway epithelium, one on the leukocytic infiltrates, and one on a special group of cells called regulatory T cells. As clinicians, when we assess for asthma activity, we need to first establish whether there's a correct diagnosis, and we do that through history. Episodic symptoms, characteristic triggers, cold air, respiratory viruses, pets, dust, characteristic response to our existing medications, which are asthma controllers. They are not disease modifiers. And then we listen to the chest, we hear musical, polyphonic wheezing on expiration, and we do diagnostic testing, like lung function testing, to measure how constricted those airways are as patients breathe in and out. This is an example from spirometry, a pulmonary function test, where the patient takes a deep breath in a handheld device and blows really hard as they can and as fast as they can into it. And going north is exhalation, going south is inspiration, and this is flow. And so that reaches very quickly a peak expiratory flow rate, and then that trails off over time. And if that individual blowing had connected the dots from PEFR to FEF50 to FEF75, that would be a normal response. But this flow volume loop is coved. This is characteristic of obstruction, early closure of tightened airways. So to study this in the lab, Raja Abdul-Noor led a series of investigations where we got precision-cut human lung sections, put them in a dish, and we measured under the microscope the contraction of the smooth muscle airway. And so in the leukotriene D4 was used as a contractile agonist. And you can see the concentration response here of LTD4 stimulated airway contraction. And you can see in the black circles, leukotriene D4 in a vehicle. So there was no SPMs present. And what you can see is we went from 100% of baseline in this concentration range down to about 50%. So we're seeing about the airway narrow by about 50%, which is very strong airway contraction. And in this set of experiments, we looked at a series of molecules known as the MCTRs. These are SPMs. AM stands for merizin, and it's merizin conjugates of tissue regeneration. These are peptidolipid mediators. A glutathione has been adducted onto the merizin backbone. And so these are cystinyl SPMs. We've heard of cystinyl leukotrienes. Leukotriene D4 is a good example. And there's drugs available, such as montelukast, as a cis-LT1 receptor antagonist. So this is identified MCTR1, 2, and 3, as MCTR1 and 2 are partially relieving the LTD4 initiated contraction. MCTR3 quite profoundly blocks the LTD4 contraction. We looked at this in vivo. Mice can't really hold a spirometer, so we have to look at it in other ways, and we do this by invasive testing as a bronchial response to methacholine, a cholinergic agonist. And here we're looking in a model where mice get exposed to chicken ovalbumin, a novel antigen for them, and they get sensitized to that, and then we introduce it by an aerosol into the airway, and it develops an allergic airway response. And in some animals, after fully inflamed, we then, in a therapeutic approach, introduce MCTR 10 nanograms intravenously or a vehicle control. Here's our window for discovery. Naive animals responding to methacholine. This is the resistance of the respiratory system on this ventilator. And you can see when they've been exposed to allergen, OVA plus vehicle, they have a much more significant increase in the resistance of their airways to methacholine. Well, what we found is that MCTR 1, 2, and 3 moved that whole response down, quieted it down, closer to the naive animals. Again, MCTR 3 being the most potent molecule. So it's promoting, remember, we didn't give it until after the animals were fully inflamed. So this is promoting a resolution of the airway hyperresponsiveness. And I'm not showing you here, but it's in our publication of the lung edema and inflammation that was associated with this. This publication was picked up by a colleague, unbeknownst to us, who found it really impactful and got it published in the New England Journal as part of the clinical implications of basic research. The biosynthetic pathway for the MCTRs is shown on the left. DHA initially being converted enzymatically by a 12-lipoxygenase. I just want to highlight that because I'm going to come back to that in a minute. And then the nice illustrations illustrating the findings I just shared with you, the raw data from. So this is balancing the effect of leukotrienes in asthma. Clinically, if there are anybody in the audience who's prescribed a cis-LT1 receptor antagonist like montelukast, most patients don't really respond that well to it. There are some that do, but many don't. And it turns out that it's probably because there is a whole endogenous resolution system that blunts cystinyl leukotriene actions. And this lifted the veil on this whole counter-regulatory pathway. Well, I mentioned the MCTRs are a product of 12-lipoxygenase activation. Here's DHA being converted by a 15-lipoxygenase, so another mammalian lipoxygenase, a distinct enzyme. And then here you get protectin conjugates of tissue regeneration, PCTR1, as well as a molecule known as protectin D1 that Charlie introduced to you just a few minutes ago. This was really interesting to us. We found these PCTRs in human lung along with the MCTRs. Protectin D1 has been detected in exhaled human breath in very low amounts and is a potent regulator of allergic lung inflammation. And PD1 actually has the properties to inhibit influenza viral replication. A group in Japan has demonstrated this in a Cell paper. In this vignette, I'm going to focus in on respiratory syncytial virus. RSV is very prominent right now in the United States and across the world. This is the genome. It's very simple structure, but a very nasty respiratory virus. I'm just going to point out nucleoprotein N, because I'm going to come back to that in a minute, and the polymerase L, so the N gene and the L gene. This is relevant in Spain. This is data that was published recently in the BMC Infectious Disease Journal about the burden of RSV-associated lower respiratory infections in children in Spain pre-pandemic, leading up to the pandemic. And RSV has only become more prominent since the pandemic. It's their conclusion from their findings, RSV-related respiratory infections remains a leading cause of infant hospitalization in Spain. Effective antiviral treatments and preventive vaccines are urgently needed, and there's been some good progress on vaccines, but we don't have treatments. So we need this for the management of RSV infection in children, especially those aged 6 to 12 months. So we obtained from Nick Lukatz at the University of Michigan a clinical strain of RSV called Line 19, and we inoculated the animal with this human clinical strain of Line 19 and followed the pattern of the infection and its resolution. And this is an airway infection, especially prominent changes in the airway epithelium. And you can see at day 3, 6, and 12, by day 12, the airway epithelium is now starting to look normal again. If you look at placable virus, detectable virus in the lung, you can see we can find it at day 3, it peaks at day 6 and is coming back down by day 12. And one prominent cytokine in the viral host response is interleukin-13. Shown here, it follows the same time course as virus. And this interleukin-13 is being produced by two distinct cell types: innate lymphoid cells type 2, which is the lineage negative cells here on the left, and T helper cells type 2 on the right. These are CD4 effector T cells, and you can see their time course. At day 3, the innate cells, which are already present in the lung, they're producing more IL-13 than the adaptive response, but you can see the adaptive response catches up. So Kate Walker in the lung looked at protectin D1 and PCTR1 in RSV infection in these animals, and I'm just going to emphasize the airway epithelial part of this story. So here the animals get infected, and then at day 3, PCTR1, protectin D1, or a vehicle is given to the animals, 100 nanograms, and once a day for 3 days, and then we sample the animals at day 6, which is peak for all those responses I shared. All right, now here's the N gene, and here's the L gene. This is by PCR. The PCTR1 is in the light blue, PD1 in the royal blue, and you can see that there's lower amounts of detectable PCR products of both N and L gene. So the RSV is not only lower in abundance, it's replicating less in this scenario. So this is not immunosuppressive, it's actually an immunoadjuvant treatment. Here's the tissue histology. You can see naive to RSV infection, lots of inflammation in the deep lung as well as the airways. And with PCTR1 and PD1, even at these very low magnifications, you can see there's much less inflammation going on. When we looked at eosinophil counts, neutrophil counts, they're lower with the SPMs. NK cells are lower. NKG2D positive NK cells, which are your NK cells that are directly targeting virally infected cells, there's less of those with the SPMs. We looked at campylocydin, one of your host airway antiviral proteins, and you can see that in the vehicle in gray, infection lowers the amount of this detected by RNA in the airway, and this is at least partially raised by the SPMs. And here's the interferons. Interferon gamma, CD4 positive T cells, which we came to know a lot about in the setting of COVID, causing all kinds of inflammation. With vehicle, you can see they're way up with RSV infection, and it's dampened by the SPMs. And then in the right there is interferon lambda. Interferon lambda is one of the type 3 interferons, and you can see that that's suppressed by infection with some increase with PCTR and PD1. There has never been an endogenous molecule identified to date that induces interferon lambda. And so we cultured human airway epithelial cells, infected them with RSV, and you can see from naive to vehicle, there's a tiny amount of detectable interferon lambda in the human airway epithelial cells. But look at what happens with PCTR1 and PD1. Marked induction of interferon lambda, very important protection against respiratory viruses. So this schematic illustrated the findings with the SPMs of less RSV virus, less inflammation, more interferon lambda. And this highlights the importance of this observation. In the airway, our first line of defense against respiratory viruses is interferon lambda. It's these type 3 interferons that have the antiviral activity without the pro-inflammatory response. The type 1 interferons is when that first line of defense gets overwhelmed. And sure, we have the epithelial responses, but now we've engendered a huge inflammatory response to that virus. And again, we saw the clinical consequences of that with COVID. This group in Lancet Respiratory Medicine, understanding this observation, developed PEG interferon lambda to give in this phase 2 trial to outpatients who were infected with COVID-19. And here's in the vertical axis is the proportion of patients negative for SARS-CoV-2 virus, and on the horizontal axis is viral load at baseline in a log scale. And in the blue there, you can see PEG interferon lambda relative to the red control. And this shows that you have a much higher probability of SARS-CoV-2 clearance by day 7 when you have those higher loads and get exposed to PEG interferon lambda. The phase 3 trial came out in late 2023 in the New England Journal of Medicine. And in the orange, syringe there, that's the active PEG interferon lambda. In the blue is placebo. And when you look at hospitalizations or ED visits, when you look at whether you're vaccinated or unvaccinated, and even mortality and really severe outcomes, the individuals who received the PEG interferon lambda had advantage over those who got placebo. So an endogenous system that is ramping up interferon lambda is quite protective. I just wanted to show you a couple slides on this story, which is led by Nandini Krishnamurthy in our lab on Merizin-1 accelerating the resolution of type 2 inflammation, again in this RSV model. But here, when we give Merizin-1, again, 10 nanograms per animal at day 3, and look at day 6, we see wonderful decreases in inflammation in the airway, and the structural changes to the airway have quieted down quite a bit. But it wasn't because of interferon lambda. What was going on was with MAR1, we were seeing decreases in IL-13 production by innate lymphoid cells and the adaptive T helper type 2 cells. And this was mediated in data that's in the publication by activation of suppressor functions of regulatory T cells. So this is targeting a different arm of our control mechanism cellularly to control T cell activation and the downstream inflammation because of that. Okay, so I'm going to move on now to talk about Resolvin D2. And to introduce this is a slide that I really like from one of my colleagues, John Fahey, because in the red here, we're depicting type 2 inflammation in asthma. It's highly associated with asthma. Some people have a lot of it, some a more moderate, and some a lower amount. But there are other people with asthma that have non-type 2 mechanisms. So there's a heterogeneity of asthma traits. It argues really against a single disease mechanism. So we need something that's more broadly acting when we're talking about asthma. This was in the New England Journal in 2022 to highlight what we know at the cellular and molecular level about the airway in asthma. And in the red there, and the reason why this is small print is because I don't want you to look at the details, but look at the publication if you're interested. But in the red bar across the top is everything we know about type 2 high asthma, and in the blue, type 2 low asthma. You notice the red bar is a lot bigger. The white boxes with the text in them are biologic drugs that have been developed by pharma to attack and block different aspects of the biology, the pathobiology in asthma. And you can see them on the slide here as an image, but there's none on type 2 low asthma. We have no therapies really here, and this is where neutrophils, Th1, Th17, and mast cells are most active. So we need new ways to think about asthma therapeutics. The genetics of asthma are quite instructive. To summarize, they're associated with several single nucleotide polymorphisms in several genes, again emphasizing this heterogeneity, a syndromic diagnosis. Few of the single nucleotide polymorphisms are associated with all ages. Those that are highlight epithelial damage and activation of inflammation. And then the loci that are really strongly associated with allergy and IgE elevations are generally not significantly associated with asthma. And this was in the New England Journal in 2010, a huge GWAS study that was done. And there are several, if you look at the horizontal line there are several genes where there was variation associated with genome-wide significance in asthma. And here you see there's 5 of them that were loci linked to serum IgE at the top. And you can see those below that are associated with asthma. And the only one where there's overlap is IL-13. All the others, no overlap whatsoever. So again, this is a heterogeneous syndrome. There's clearly gene by environment interactions for the clinical expression of asthma. Well, Investigators in the UK tried to prioritize some of the genetic variation of candidate causal genes for asthma in susceptibility loci from an enormous data bank, the UK Biobank, of genome-wide sequencing studies. And one of the genes that popped up in this analysis was DRV2, GPR18, which is the Resolvin D2 receptor. So we wanted to study this in more detail. Hong-Yong Pei in the lab, now using the common allergen house dust mite extract for sensitizing and then challenging the animals, generated allergic airway responses, and then on day 15 or 16, we either gave a vehicle or Resolvin D2 right into the airway. And then we could analyze the animals for the week thereafter. In the red here are the animals receiving Resolvin D2, and in the black, vehicle. And this is now emphasizing those leukocytic infiltrates. And so you can see total cell counts in bronchoalveolar lavage, where we put in salt water and we take it back out again. We see much less in the way of cellularity with Resolvin D2, especially eosinophils, much lower, lymphocytes, lower. And then Charlie introduced the resolution interval, and when we look at this from day 15, which is where we start to give the Resolvin, it takes 7 days to go from that value of BAL eosinophilia to half of that value. It takes a week. If vehicle with Resolvin D2, it takes a day. Marked acceleration. Maybe it's going up instead of. Look at the tissues. This is by histology. Saline controls. There's the model, allergen sensitized and challenged, intense inflammation in the tissue, marked changes around the airway, and those animals that got Resolvin D2 just a few days later, you can see there's much less inflammation present. This is PAS staining mucus, so the mucus cell metaplasia that I described in asthmatic airway. You can see in the purple, and you can see there's marked increase with this model in mucus cell metaplasia, much quieter after receiving Resolvin D2. Very profound effects. And then how about the lung function, which I've emphasized before? This is at day 17. The naive is the dashed line, and the solid line is when the animals received a vehicle. That's the max response. And this is by fold change over the baseline. You can see at day 17, the animals that received Resolvin D2 had much less in the way of airway reactivity. And by day 21, it's the same as naive. It's resolved. Whereas the animals that got vehicles still have significant airway hyperreactivity. And you can quantitate this also by looking at the effective dose that causes a doubling of the airway resistance. And you can see in the red there, it just takes more methacholine to tighten the airways with Resolvin D2 than it does with vehicle. So another protective action there. The type 2 cytokines in the BAL fluid were all decreased with Resolvin D2, IL-4, IL-5, IL-13. Even total IgE is decreased here at day 17 and day 21 in this model with Resolvin D2. We wondered about the link to the receptor. Of course, the receptor was the reason we got into this. And there's a receptor level antagonist, O1918, for the DRV2 or GPR18. And so when we use that, these protective benefits in red of Resolvin D2 were blocked by the Resolvin D2 receptor. So this is Resolvin D2 engaging its receptor and signaling for an acceleration of resolution of the allergic airway responses. In humans, when we take peripheral blood, and I'm just emphasizing those cells in the kind of asthmatic response, if you will, what we see in asthma on the right there, health on the left, is an expansion in B cells, CD8, CD4 T cells, as well as eosinophils. Which of those cells are expressing more of this receptor of interest? By flow cytometry, we look at the MFI for the Resolvin D2 receptor, and most impressively, in the purple there, you can see that the eosinophils in asthma have a marked increase in receptor expression. So Tazy Brueggemann in the lab wanted to study this in a little more detail and looked at the whole lung, not just the BAL, in this model, and she looked out for longer periods of time. And it turns out that in the light blue there, those are the animals receiving Resolvin D2, total lung eosinophils, you can see this marked decrease, not all the way to zero, but marked decrease in eosinophils. And it turns out that this RBD2 is targeting a specific subset of activated eosinophils. And you can distinguish the activated eosinophils from the more quiescent homeostatic eosinophils by this flow cytometry marker, CD101, low and high. And here's just a couple examples. I refer you to the paper. This got the Paper of the Year award from the journal, actually. It was very exciting for Chasey. CD101 low cells expressing CD11B, Charlie mentioned this was a target of SPM regulation of leukocytes. You can see CD101 highs in day 17 have a much higher level of CD11B expression, and that's significantly blunted by Resolvin D2. We wanted to look at function, and eosinophils respond to the mast cell product prostaglandin D2 quite profoundly. And so this is looking at the prostaglandin D2 receptor, DP2, CRTH2 by MFI, marked increase in expression in the CD101 high eosinophils relative to CD1 lows, but no regulation at the level of expression by Resolvin D2. Well, how about function? When we expose the CD101 lows that we've flow sorted to prostaglandin D2 and look for eosinophil peroxidase release, we don't really see it. We don't see RBD2 or PGD2 release. But when we look at the CD101 high cells, prostaglandin D2 significantly releases, degranulates the eosinophils with eosinophil peroxidase, and that's significantly blunted by Resolvin D2. So RBD2 is regulating cell function. If you look at plasma levels in severe asthma relative to health, there's significantly less available Resolvin D2 in the circulation relative to healthy control subjects. This is yet unpublished. We're putting the manuscript together now. So what I've tried to describe for you is 4 vignettes targeting asthma-relevant targets in the airway. So the MCTRs targeting airway smooth muscle, PCTR1 and PD1 targeting airway epithelium, RBD2, the leukocytic infiltrates, and as you saw, I briefly alluded to the Merizin-1 story, and regulatory T cells. So if we summarize, then here we've presented evidence that for allergen or viral-driven type 2 airway inflammation, SPMs accelerated the resolution of lung inflammatory cell counts, type 2 cytokines, IgE, mucous cell metaplasia, and airway hyperresponsiveness. The actions were receptor dependent, and the receptor expression was present and modulated on the leukocytes. After HDM, lung mouse eosinophils were spatiotemporally regulated with an activation phenotype distinguished by CD101 expression. CD101 low and high EOs were, and data, it's in the publication, just for time, I didn't show you today. They're morphologically, transcriptionally, and functionally distinct. RBD2 could regulate eosinophil numbers, transcriptome, activation, and function. So in conclusion, unraveling endogenous systems of resolution has revealed that Resolvin D2 is a potent SPM agonist for mouse type 2 cytokine evoked allergic inflammation. The the IL-4 was represented by the profound decreases in IgE. IL-5, the regulation of the eosinophils. IL-13, the regulation of the mucous cell metaplasia and the airway hyperresponsiveness. And RBD2 regulated eosinophils with a specific phenotype and function in a DRV2 dependent way, and DRV2 expression in leukocytes really suggests that this receptor could be a regulatory target for a broad spectrum of patients with asthma. I like this slide from a very early review that Charlie did in Scientific American for the public to better understand these immunoresolvins as agonists for catabasis. Catabasis is a military term from the battlefield to clear the battlefield after the battle has been waged. And so catabasis here, the battlefield is inflammation, and I've shared with you the lung as the site of that battle. And so these agonists resolve that battlefield and restore some adaptive form of homeostasis and function. So we're very accustomed to clinically used medicines like etanercept, infliximab, NSAIDs, as mentioned by Charlie in his talk, biologic targets of adhesion molecules or other cytokines, even cyclosporin for regulating IL-12. But here the SPMs in the center of this are serving as agonists at cognate receptors with very low nanomolar affinity binding. And they stop granulocytes and they non-phlogistically, non-fever forming activate monocytes and macrophages for the clearance of that battlefield. So I'm going to end by thanking the folks in my lab. I've tried to highlight them along the way, the people I've worked with, Tazy and Elaine, and Melody, and Nandini, Human, and Luciana for this talk in particular, but I work with some unbelievably wonderful people. I'm very lucky. Charlie in the Center for Experimental Therapeutics and Reperfusion Injury at the Brigham, as mentioned, very close colleague, and folks in his lab like Nan and Robert. I have wonderful collaborators in the Asthma Research Center, Elliot Israel and Angeles in particular, and we're funded as part of the asthma work by the Severe Asthma Research Program from the NHLBI and more generally our funding from the NHLBI. And thank you very much for your attention.
Thank you. Next speaker is Dr. Deepak Panigrafi. You know, from the Harvard University too. The title of the presentation is PMS, the resolution of cancer inflammation, that he's a good expert in this issue, no? The Dr. Deepak Panigrafi investigates the role of bioactive lipids in cancer biology, particularly how they influence of tumor growth, metastasis, and angiogenesis. He studied lipid mediators. He has a lot of experience, you know, in the effects on cancer progression. His research also examined how chemistry induces some problems, you know, in the cells, and especially inflammation and cancer recurrence, aiming to improve treatment outcomes. Additionally, he explored the potential the specialized resolving mediators to promote tissue regeneration and inhibit tumor growth. Dr. Pesaki work seeks to develop new therapies that leverage this finding in the cancer treatment. Okay, thank you very much. You can stay when you want. Thank you.
Thanks. Thank you to the foundation. Thank you, Solutex. It's my second time to Madrid. Got to visit the Solutex factory last time. This entire lecture is really inspired, dedicated to 40 years of research from Dr. Serhan. I was going to be a liver transplant surgeon. I worked with Roger Jenkins, who did the first liver transplant in Boston. And so I was going to be in the operating room all the time. And then I fell into Dr. Folkman's lab. And then Dr. Folkman pioneered about 50 years ago that the tumor microenvironment is more than just the tumor cell, you can see here, but the tumor environment. And that's the blood vessels back 50 years ago. But we know today the tumor microenvironment is endothelial cells, fibroblasts, neutrophils. We're going to talk about the tumor macrophages, the big eaters that clear debris. Most of the cancer field has focused on cytokines, but upstream of cytokines, we're going to talk about lipid autocoids. Inflammation from Hanahan and Weinberg's famous hallmarks of cancer is one of the newest hallmarks of cancer. You can see here, this is a study by Rector, where in people, not just in animal models, but in people who had atherosclerosis and were given a neutralizing antibody to IL-1 beta, they had reduced lung cancer. So it started to be some of the human evidence that blocking inflammation could reduce cancer growth. In fact, here is, if genetic damage is the match that lights a fire, inflammation is the fuel that feeds the flames. And in fact, today, inflammation through DNA damage can actually initiate cancer growth. So it's a new paradigm that inflammation not only promotes tumor growth, but can initiate tumor growth through oxidative stress, DNA damage, and genotoxic mechanisms. Inflammation and cancer has a very hot link. You can see people with smoking, hepatitis, we're going to talk with liver cancer, alcohol, esophageal cancer, asbestos, mesothelioma. So people without obvious cancer who have chronic inflammation are at risk for cancer. And this is a big clinical problem. For example, if you have ulcerative colitis, you have a 5 to 10% increased risk of cancer. Do you get scoped every year, or do you have your colon removed, which would be very invasive for somebody in their 30s and 40s? I'm going to talk about some diseases. Dr. Levy had mentioned cystic fibrosis. I'll talk a little about Fanconi anemia. And these populations have chronic non-resolving inflammation, and they're at risk for various types of cancers. The other problem in cancer is that not only does chronic inflammation increase your risk of cancer, but the conventional therapies that every cancer patient gets can also stimulate inflammation. So even though these therapies have a benefit, and that's why their surgery is frontline therapy, chemotherapy, radiation, anesthesia, but what's even known now, immunotherapy, which won the Nobel Prize James Allison in 2018, in a subset of patients can regress tumors. But the problem is that all these therapies stimulate inflammation, and it can be chronic inflammation through, and we'll get into cellular debris. There's been no paradigm really change over the last 100 years in treating the inflammatory diseases. And you heard from Dr. Serhan, Dr. Levy, about the side effects. Steroids, they suppress the immune system, and the last thing you want in a cancer patient is to suppress your immune system. Non-steroidals have stomach bleeding, heart toxicity. COX-2 inhibitors increase thrombosis, heart attack. You heard about the class switching. If you block prostaglandin E2, that can actually delay the class switching. So there's multiple reasons why, and I'll get into why blocking pro-inflammatory factors has been a double-edged sword. Biologics, anti-TNF, increase your chance of cancer, lymphomas, infections, TB, and even blocking NF-kappa B can promote cancer. So really, I would say 100 years, 200 years from now, when people look back on inflammation resolution, these are three key figures. John Hunter was a Scottish surgeon who actually, if you read his writings, he said inflammation itself can be beneficial. It's not necessarily harmful. And William Coley, American oncologist, actually took the pus and actually injected sarcoma patients and got regression in a subset of patients. He was so far ahead of his time that he was ridiculed, laughed at, and then today he's pretty much considered the father of immunotherapy, because that's what using pus to stimulate your T cells is kind of was a rough version of immunotherapy. And then in 2000, Professor Serhan asked, what turns inflammation? What are the stop signals? If the soil causes disease, the cure to the disease also lies in it. So rather than blocking pro-inflammatory factors like eicosanoids and cytokines, he took the reverse approach and in an unbiased way. You heard before about the mouse dorsal skin air pouch assay. Found which lipids are responsible for turning inflammation off. And in cancer, this is a huge deal because tumors produce over 30, 40 pro-angiogenic, pro-inflammatory factors. So that's why blocking a single eicosanoid or a single cytokine has not worked to date. VEGF, and there's certain agents that have some effect, but it hasn't been really dramatic. This is, if you look at over the past, since 1985 with the birth of the lipoxins, that SPMs as a class is over 5,000 publications. And Resolvins was 1882 on PubMed as of this morning. From a cancer point of view, why SPMs would be a potential chemopreventative, not only a therapeutic, because they're anti-inflammatory, they clear debris, which I'm going to get into why that can be bad. They're anti-fibrotic. Many cancers, such as pancreatic cancer, are stimulated by fibrosis. Like pancreatic cancer is like a softball, it's very hard, and it doesn't allow chemotherapy to penetrate the tumor. So a drug that's anti-fibrotic, the FDA in the US will give automatic approval to because it allows chemotherapy to penetrate the tumor. The Resolvins are anti-angiogenesis. Judah Folkman was the first pioneer that tumors need blood vessels to grow. And also SPMs are anti-infective. About 25% of cancers worldwide are related to infection. They block pain, and very importantly, are not immunosuppressive. This was one of the first papers, really, which kind of showed that tumor cells, neuroblastoma tumor cells, have the enzymes to generate resolvins, 15 locks, 5 locks, but do not produce resolvins. And this is a quote from the paper: the absence of resolvin production, despite presence of the enzymes required, may be a survival strategy for neuroblastoma cells. And Dr. Serhan showed, this was the April issue of National Geographic dedicated to SPMs. And in here, a quote, chemotherapy, radiation are like, we talked about sledgehammers. They can kill the tumor, but the debris that they create can stimulate inflammation. This is an important concept because people wonder why cancers come back after several years. In ovarian cancer, it can be 1 to 2 years. Breast cancer, it may be 10 years. But most cancer drugs do not kill all the cells. Some cancer cells in the tumor survive exposure and transition to a more stem-like malignant state. And those that survive may be stressed and strengthened by the treatment. And this can be through, like chemotherapy can increase cancer stem cells, can increase pro-inflammatory factors. And so one of the historical concepts that was very important in the cancer field is Laszlo Revesz showed that radiation induces apoptotic cell death, which is debris that stimulates tumor growth. And this is counterintuitive because the whole goal in cancer therapy is to induce apoptotic death. You want to kill the tumor. But the people in the radiation field know this concept very well about hyperpopulation. And the other problem is that many of us have dormant tumors. And we know this from car accidents. Pathologists, for example, in Finland studied people who died in car accidents. Over 90% of people have dormant thyroid cancer. Over 40% of men have dormant prostate cancer. Over 30% of women have dormant breast cancer. And any wound, injury, trauma can cause dormancy escape. And so that's something my mentor, Dr. Folkman, we study in the lab. And so with Dr. Serhan, when Megan was in the lab, we basically took the Revesz phenomenon and used chemotherapy. And chemotherapy itself, the cell death, the apoptotic cell death that you generate can stimulate tumor growth. Here you can see that the debris alone doesn't produce a tumor, but when you increase the amount of debris, you get a dose-dependent increase in tumor growth. So that's chemotherapy-generated debris. You can get radiation-induced debris, surgery-induced debris. And the mechanism, one of the mechanisms is that chemotherapy such as cisplatin or vincristine can generate, LLC is a tumor cell, Lewis lung, melanocytes, or a normal cell type, primary fibroblasts we did just to show it's not specific to a cell line, but you see what we call the cytokine storm. And that's really the problem in cancer. We have so many cytokines. If you're going to do an anti-neutralizing antibody to, let's say, IL-6 or TNF-alpha, eventually in aggressive cancers that are metastatic, stage 3, stage 4, it's not going to work. And we actually used liposomes to show it was a signal, the apoptotic debris. So it's not even specific to tumor cells. So if debris contributes to cancer, how can it be cleared? And this is a new approach in cancer, and it really uses, we talked about phagocytosis, Metchnikoff, who discovered the macrophages. And in healthy people, more than 10 billion cells die every day, and our macrophages will clear the debris. And here you can see macrophage RVE1 at just 1 or 10 nanomolar stimulated the eating of tumor cell debris. And even efferocytosis, we labeled tumor cells with GFP. We looked at efferocytic markers, TIM4, and resolvins could not only increase phagocytosis, but that eating of debris, the efferocytosis. And what was very exciting is that just 1 nanomolar of RBD1, RBD2 could downregulate or counterregulate a series of cytokines. You can see the gray on the left is without debris. When you add debris, you get an increase in pro-inflammatory cytokines in general, and the resolvins would counterregulate that. If you try to neutralize these cytokines in mouse models or in people, the tumor will just escape. And the resolvins polarize the tumor macrophages to an M2-like pro-phagocytic, pro-resolving phenotype. So if you look for phagocytic markers, we were looking at CD11B or M2-like macrophages. That was one of the mechanisms, and other groups have shown this with lipoxins and resolvins in different tumor types. And this was the picture Dr. Serhan showed. What's really important here is that the resolvins are at nanograms per day. That's over 10,000-fold lower than chemotherapy, which is at grams per day, or Celebrex, dexamethasone, are at grams per day. Eventually, these tumors did escape, and that's where we add chemotherapy and other therapies in combination with the resolvins. So surgery itself induces dormancy escape. This is a classic study by the Fisher brothers at University of Pittsburgh. Bernard Fisher won the Lasker Award, I believe, twice before he passed away at University of Pittsburgh. And what they did is they took rats and just injected only 50 Walker cancer cells in the portal vein, which goes to the liver. And if you let the rats just sit there for 5 months, they don't grow any tumors. You don't get any dormancy escape. But just subjecting the rats to a laparotomy, which is you sleep the rat, and then you make incision in the skin, you expose the muscle, and take out the colon and put it back. You don't inject any more tumor cells. So just the act of anesthesia and surgery stimulated dormancy escape. And this is well known in the surgery field. Hanahan, Weinberg, other investigators in Israel are now actively searching, testing clinical trials at the time of surgery with beta blockers and COX-2 inhibitors, trying to block this inflammation. Several years ago with Charlie, we had a paper where this is where if you give chemotherapy or surgery, you have a transient reduction of the tumor mass. But at the time of surgery, about 24 hours before surgery, if we gave the resolvin, or we actually used ketorolac because that would also indirectly boost the SPMs, such as lipoxins and resolvins, you could get resolution of inflammation, long-term survival in a subset of animal models. So this really told us at the time of surgery, if you wait too long to dampen the inflammation, the surgery-induced inflammation already has done its damage. And same thing with chemotherapy. The problem with cancer therapy is you have to wait pretty much 8 weeks after surgery sometimes to start the chemotherapy, and most people during radiation or chemotherapy do not get an anti-inflammatory to prevent the radiation or surgery-induced inflammation. And this is just a great example in the lab. Like, if you really want to believe something, you test it in the lab, one of the advantage. The only difference between this group has surgery and the group below did not have surgery. They're both injected with 1 million ovarian cancer cells that normally would take 3 months to grow ascites, which is the fluid that the mice at the top have. And the only difference is the mice in the top got a mini osmotic pump. So the act of surgery basically accelerated tumor growth by over a month. And what was really exciting is we used resolvins to clear the debris, and we can prolong survival in this model of ovarian cancer. And now the field has really taken off. There's colon cancer, cervical cancer. This is really an interesting paper, this liver paper. They use Resolvin D1 and E1 to block the switch between hepatitis and liver cancer. I'm going to talk about cystic fibrosis, Fanconi, and other syndromes. This is a preclinical model that's using a non-toxic lipid, such as Resolvin, in your body, and this has high relevance for people who are at high risk for cancer. And then this is where Resolvin D1 could block cancer stem cells. And I mentioned that what's really exciting is that the Resolvins clear the debris that radiation and chemotherapy can induce. So they can enhance, in this paper, Resolvin D1 limited radiation-induced tissue damage, can reduce chemotherapy-induced toxicity, which is very important when patients have dose-limiting toxicity for their chemotherapy, can improve pain. OSE Immunotherapeutics in France had a ChemR23 agonist because Resolvin E1, one of the receptors is ChemR23, and they just had about $15 million agreement with AbbVie to license ChemR23. And in this paper, what was really neat is they got colon cancer regression when they added the ChemR23 agonist to chemotherapy. As far as mechanisms of Resolvins, they can reduce oxidative stress, they can reduce chromosomal instability. We talked about angiogenesis, fibrosis, and those are some of the tumor microenvironment mechanisms. What's also exciting is that Resolvins have direct anti-tumor effects, which we were a little surprised because when we looked at tumor cells, the receptors were expressed at a lower level. But you see inhibition of cancer stem cells, inhibition of epithelial mesenchymal transition is how tumors can metastasize, DNA damage, oxidative DNA damage, you have inhibition of proliferation of tumor cells. So not only do you have a lipid that's in your body that works at nanogram concentrations, but it has direct anti-tumor activity and effects on the tumor microenvironment. And we talked about pain, and these are just some of the papers. I didn't list them all, but chemotherapy-induced pain is very important in the clinic, and you can see bone cancer, SPMs can reduce that. We're very interested, we and others, as you know, in the diet, because cancer patients, that can immediately impact their cancer with the diet. And what's well known in the literature, if you treat mice with a high omega-6 fatty acid, you pre-treat for 3 weeks, that stimulates metastasis in general. It can disrupt resolution. Even though omega-6 can generate protective lipid mediators, you do have more pro-inflammatory mediators that disrupt resolution. And we talked about omega-3 fatty acids, which, you know, I heard Madrid is #2 in the world to Tokyo for eating fish. And this supports eating fish as a kind of blocking inflammation, promoting resolution, inhibiting cancer. Dr. Serhan introduced the concept of precision nutrition. You can see in these reviews, you can see Liponova from Solutex and several of these papers. Some of it's by nutrition like blueberries, exercise, yoga. These all can increase your SPMs. The cancer surgery paper from Japan, they had patients with liver tumors who they gave EPA, and the EPA triggered Resolvin E1, which counter-regulated interleukin-6. So there is a scientific evidence for perioperative immunonutrition, certainly with SPMs. The last couple slides are going to show a couple different projects in the lab that are ongoing. With Dr. Serhan, we have a new NIH grant to study cancer cachexia. That's the muscle wasting disease, really a systemic inflammatory disease where cancer patients, up to 80% of cancer patients get this muscle wasting. It can be wasting in the brain, it's systemic inflammation. 20% will die directly because the muscles in the heart and lung won't work. There's no drugs currently for cancer cachexia. And so we really asked the question, is there a failure of resolution? And as Dr. Serhan showed, and this is really unique with cancer, I know of very few, if any drugs, cancer drugs, that promote wound healing and promote tissue regeneration. In fact, this is why one of the reasons this grant got funded is because they realized there's very few approaches that are anti-tumor and promote regeneration. And so basically what we did is in a mouse model, we took cachexia and no cachexia. Really one of the unsolved problems is why do some cancer patients get cachexia and others don't? It's not related to tumor burden or metastatic burden, so nobody knows that. But you can see here that when you have the loss of SPMs, that could predict which mice got the cachexia. And here, by using a replacement treatment model, we could get prolonged survival in pancreatic cancer cachexia. In fact, in clinical patients, they use grip strength in clinical trials because instead of waiting for the end stage for someone to die of cancer, which could be 2-3 years, there are markers of how a patient, their strength, and one is grip strength, and the SPMs can improve the grip strength. This is a genetically engineered model. Another project we have with Dr. Serhan, which is really, can drugs which induce apoptosis cell death increase the risk of cancer via loss of resolution? And this could be tamoxifen, because a subset of breast cancer patients, tamoxifen, get endometrial cancer. That generates debris. Steroids, prednisone can increase your risk of cancer. What we're very interested in is transplant. So immunosuppressive drugs like cyclosporin, tacrolimus prior to transplant, those patients have an increased risk of cancer. And Dr. Levy had talked a little bit about cystic fibrosis, and that's a growing problem in the field. You see in colorectal cancer, there's a 27-fold increase of colorectal cancer after transplant for cystic fibrosis. In fact, now people are starting, this is a project that Charlie and I are doing with Steve Friedman, and really, do these patients need to be scoped more aggressively because they're at increased risk of cancer. You can see even the carriers who only have one gene are at increased risk of colorectal and pancreas. And actually, I was looking at last night, in Spain, 1 in 25 people are a CF carrier. So I was calculating in that new soccer stadium, 85,000 people, about 3,400 are carriers. And if the dad and the mom are carriers, their kids have a 25% chance of being both genes and getting cystic fibrosis. So the good news with cystic fibrosis, now people are living into their 60s, 70s, you know. When I went to medical school, you know, you didn't live that long, but now the challenge is that these patients are getting more cancers. And we actually have a mouse model where we use CFTR, genetically engineered mice, and you can see increasing pancreas cancer, lung cancer. Certain cancer types are especially seen. And if you look at the enzymes that generate SPMs, such as 12-LOX, the CYP, COX-2, you see an increase in the enzymes. It kind of reminds me a little bit of the Swedish paper with Charlie on. But then if you do debris with cyclosporin or tacrolimus, that generates cell death. And this has been studied, well studied with SPMs in cystic fibrosis. We're just approaching with the cancer model. And you can see in lung cancer, you see a loss of SPM precursors, the 14-HDA, 18-HEAP. These are early studies, but it's showing that the enzymes are there to generate the SPMs, but the SPMs are either dysregulated or lost. And this was an experiment with Charlie. We did RBD4 and MCTR1 using cytotoxic drugs to stimulate tumor growth like prednisone and tacrolimus, and we can get regression in several of these cytotoxic-driven tumors. So we're trying to mimic kind of the CF patient that gets tacrolimus or the kidney transplant patient with cyclosporin. And as far as mechanisms, you can see that Resolvin D4 will stimulate macrophage of non-tumor debris. There's no tumors here. This is actually a macrophage debris raw line. And here you can see MS1 is endothelial cells, EPH4 epithelial cells, raw macrophages. And if you add the debris, you get the cytokine storm. But if you look at RBD5, MCTR1, you heard about the conjugates. We're especially interested in the conjugates because of stimulating tissue regeneration for cachexia, but you can see a counter-regulation. You can see Celebrex, COX-2, if anything, the cytokine storm gets worse. So resolvins regulate various immune cells in the tumor microenvironment, macrophages, neutrophils, the neutrophil to lymphocyte ratio. But what's unknown in the cancer field is what about T and B lymphocytes, because immunotherapy targets T lymphocytes and NK cells and dendritic cells. And Dr. Levy has done some really elegant work with NK cells, dendritic cells. We're trying to apply that now to the tumor field. And you see in this review from Charlie and Nan, the important part is that resolvin E1 receptor is expressed by many cell types in the tumor microenvironment, not just macrophage neutrophils, but dendritic cell and T cells. And so we hypothesized, could resolvin E1 reprogram the tumor microenvironment by activating immune cells to relieve immunosuppression and promote anti-tumor immunity? And you can see, which is also bolstered by a group in Italy that showed that resolvin D series can promote anti-tumor immunity in head and neck cancer. So we have a collaboration with Thetis Pharmaceuticals where resolvin E1, the TP317 is synthesized by Thetis, a magnesium salt of resolvin E1, and they were mainly focusing on inflammatory bowel disease, but we started a collaboration with us and Thetis. And what was really exciting is that we actually developed once a week we could give the resolvin injection, and you can see a delayed tumor growth for about 3 weeks. Eventually the mice do die, but you get prolonged survival in an aggressive orthotopic model where you inject the pancreas cells right into the pancreas. And what was neat is that this particular experiment, we gave the resolvin E1 sub-Q. 15 minutes afterwards, we could detect the resolvin E1 in the pancreas tumor, in the pancreas. So there was sustained release. When we add the resolvin E1 to the chemotherapy, a subset of mice, we got prolonged survival, and we're following these mice. And then what was really exciting, whether we used poorly immunogenic tumors such as pancreatic and lung cancer, where immunotherapy is not immunogenic, meaning it doesn't work very well, or melanoma, where you can see PD-1, CTLA-4, 2 immunotherapies that today, if you have melanoma, you can get 2 of these immunotherapies, and it responds pretty well. But resolvin E1 enhanced both the poorly immunogenic and the immunogenic tumors. And what we used a receptor antagonist to BLT1, and we could block some of the resolvin E1 activity. And if you look at LTB4, BLT1 pathway, it's kind of like PG2, where PG2, some people are trying to block it to block cancer, but PG2 can also be protective by causing this class switching to SPMs. Same thing with LTB4. LTB4 has a pro-tumor pathway, but there's an anti-tumor pathway if you block where LTB4 is actually protective. And so that's why over the years, these inhibitors haven't worked in cancer trials. In fact, if you submit a grant on COX-2 inhibitors, they'll just say, you know, it hasn't worked in the clinic. Same thing with LTB4 and synthesis inhibitors and BLT1 antagonists. So resolvin E1 is acting as an agonist, so that's the difference here. And in this study, using flow cytometry, you see an increase in CD8 T cells and CD3 cells, and those are the cells that are responsible for the anti-tumor immunity. And to prove that, we actually depleted the CD8 cells, and you lose the anti-tumor activity, and even the NK cells were protective. So RV1 can act through CD8 cells and NK cells. Then we started with bulk RNA sequencing, and we were we had spent a lot of time on macrophages and neutrophils, and we got this back, and I know Charlie wouldn't be surprised because all their work with Rick Phipps, but the B cells, T cells, NK cells, you can see here, there was definitely activity. So the RV1 stimulates innate and adaptive immune cells, especially the B cells, the CD8, CD4 T cells, the NK cells. And what was exciting is that RV1 monotherapy induces an interferon gene signature, and that's classic for anti-tumor immunity. Here you can see in 3 different tumor lines, pancreas, KPC, melanoma, we had this adaptive immunity that's consistent with the interferon gene signature that you would see with immunotherapy. And then single-cell RNA-seq suggests that the resolvin broadly upregulates the machinery for antigen presentation, which is critical for anti-tumor immunity. And that was in macrophages, dendritic cells, stromal cells, and even in the tumor cells, which now we're starting to understand why RB1 has direct anti-tumor effects and effects through the microenvironment. So really, RB1 offers a novel BLT1 agonist approach to promote tumor immunity. And so it's really an exciting new approach for cancer therapy. Just a few slides left. I mentioned cystic fibrosis before because that's a population at risk for cancer. There's actually even a rarer disease called Fanconi anemia. That's a blood disorder, genetic disease, and about a 1,000-fold increase in cancer. In fact, about 40 to 50% of these patients will get a cancer by age 45, either a blood cancer, leukemia, or a head and neck cancer and anal cancer. So actually the Fanconi Society asked us to make the world's first immunocompetent Fanconi mouse model because everybody uses knockout mice. But to test immunotherapy, you need an immunocompetent C57 model, which we did. And then we combined RBD4 with anti-PD-1 RBD5. I won't get into mechanism, but TREM2 is a phagocytic receptor that enhances immunotherapy, and the resolvins can antagonize that receptor. And then the last few slides, our Italian collaborators, this is now moving to people, because what I've shown you before was preclinical models, but they asked, is resolvin E1 pathway relevant in pancreatic cancer patients? And they took the biosynthetic enzymes, the degrading enzymes, and basically using RNA sequencing from the Cancer Genome Atlas, came up with an RVE high and an RVE low based on human data, patients who've had pancreatic cancer. And the patients with an RVE high had an increased anti-tumor immunity. If you see T-cell activation, cell chemotaxis, leukocyte cell adhesion, leukocyte chemotaxis, these are all critical properties of anti-tumor immunity. And here you can see higher expression of the RVE degrading enzyme, the red, is associated with poor prognosis. This paper just came out recently. Breast cancer, resolvin levels are lower. The most aggressive breast cancers are mutated, triple negative, and proliferating. And all 3 types, you have a loss of resolvin D2, resolvin D3, and resolvin E1. So it's using plasma resolvins as a potential biomarker. And then we talked about the class switching. This was a paper from Ganesh Halad and his colleagues in Gut, just came out a couple months ago. And really what they showed was what Bruce and Charlie showed in 2001, the defective class switching, where you don't get that switch to SPMs from prostaglandins and thromboxanes, and they showed that in colon cancers. Patients who escaped and had colon cancer had defective pro-resolving lipid class switching, low levels of PG2, PG2. They did spatial transcriptomics, supported lack of lipid class switching in colon cancers. There's even more papers with resolvins as a biomarkers, but just didn't want to make the slide too complicated. We were focusing on breast cancer, but we were kind of curious about the other diseases. You can see resolvins being used as potential biomarkers. And in cancer, it's really dependent on the particular cancer type. So pancreatic cancer, this report from Poland, the lipoxin resolvins went up with the pancreas cancer. And that's what we find in the lab. Some tumor types, you get a dysregulation of the receptors, and you get an increase in the SPMs. But other cancers, such as colon cancer, bile duct cancer, you get a loss of resolvins. So it kind of depends on the particular type. But in either case, replacement therapy with SPMs to enhance, either alone or to enhance conventional cancer therapy is definitely an exciting new approach. And I'll just end with a quote from Professor Serhan. "It is time to challenge current treatment practices, especially in cancer, namely using inhibitors and antagonists alone, and to develop immunoresolvins as agonists of resolution pharmacology." And then there's just an acknowledgement slide. Thank you.
Well, thank you very much for your nice presentation. We really enjoyed, Dr. Panigrai. Thank you. Well, in 10 minutes, I will present the recently published findings on the nutrition SPMs intervention in patients with osteoarthritis, no? And later, we can moderate the table from questions, 10 minutes for questions, more or less, and later will be the closing remarks. Well, I would like to thank you for all the speakers because you have everything on time. Thank you very much. Huh? Well, here. Well, OAFI is the first and only foundation dedicated to people with osteoarthritis, no? Worldwide. I think it's, we just this morning, we spoke about the osteoarthritis is not a glamour disease. We can say it's a neglected disease. No? Sometimes patients go to the doctor and doctors say, well, you become older, it's the time, you know, you cannot do nothing. No? And this is false. This is completely false. And that's the reason that OAFI is working in this direction. No? Our aim is to prioritize the patient and place them at the center of the disease, helping them finding their voice and ensuring their concerns and to be heard. No? We are very active promoting education, prevention, treatment, and research in joint health. Our organization provides comprehensive solutions to individuals suffering from this condition, offering support, pain relief, and enhancing their overall quality of life. Quality of life is very important. Take in mind that we make 2 years a publication in The Lancet. We are part of the Lancet Commission. And in the world, there are near 600 patients, 600 million of patients with osteoarthritis. I mean, that is the most common disease in the world. Well, I will explain, you know, this is published in the BMC Musculoskeletal Disorders and also in the Journal of Translational Medicine. This is a randomized double-blind placebo-controlled study to evaluate the effects of treatment with SPMs, you know, all derivated from fish oil on chronic pain and inflammation, functionality and quality of life in patients with symptomatic knee osteoarthritis. That the name of the study is Gaudí, because I like, you know, Gaudí, and we put the name, you know, for our architect, Gaudí. Well, you know, the purpose of this study was to evaluate the efficacy of SPMs reducing pain and in patients with symptomatic knee osteoarthritis. The study was a randomized, multi-center, double-blind, placebo-controlled study. It was a pilot to evaluate the efficacy of SPMs, Lipinova, 100 milligrams in soft calcium versus placebo. It was a 3-month, 12 weeks of supplementation and final evaluation. We can see that, you know, it was the 2 groups. One is the SPMS group, and the other was a placebo group. And the treatment is, during 6 weeks, the patients take 2 grams per day, and later, until 12 weeks, 1 gram per day. And the placebo group, you know, take only the excipients. That means that was not the active principle, no? And we have the different species that you see. And in the end of the study, we make also a conference call, you know, in order to know how the product works, no? This is the chief of the doctors that they participated in the study. All of them, they are with good knowledge, you know. In this case, Dr. Gil Rodas, he's the medical director from the medical area from the Barcelona Innovation Hub. Dr. José María Villalón, that is here. I don't know, José María, where are you? Are you here? Dr. José María Villalón. He's, you know, he's a very important expert in the world in sport medicine. And he's the head of medical service of Atletico de Madrid. Dr. Greenmuller, she's one of the best rheumatologists. She's the teacher in the world from ultrasonography. He has the director from Qual Institute in Barcelona. Dr. Paco Angulo, he was the medical director from Atlético de Bilbao, from the football, we say, that soccer in the United States. And Dr. José Antonio Rodas, that also is a good expertise also in sport medicine, and he's the doctor from the national, selection of players in Spain, that we say sub-21. There are different selections in Spain. No? And why we choose that? Because, in fact, we take patients coming from sport, because we know that the SPMs, there are a lot of data coming from the United States that works in people with problems of the, joint problems coming from sport. And this, well, we can do a clinical trial well done in this kind of patients. In fact, a lot of them are, football players, and they have, one arthrosis, osteoarthritis of the knee, grade 2, grade 3, according with the American Academy of Rheumatology. The results are very interesting. In the clinical pharmacology, in osteoarthritis, we don't have we have, our scales are very subjective. And the most important is pain. This is a Hutchinson scale, and we see that good results. Even the study was made in the end of the COVID time. That is complicated to do this kind of a study because for the situation that we have. No? And we see that near 45% was patient reduction was assessed in the SPM group, compared to 28% in the placebo group. For you have an idea, we are collaborating WAFI with EMA, with the European Agency of Drugs, and Spanish Agency of Drugs, and when you have a product, more than 10% of the placebo works. For the United States, for the FDA, or for EMA, or for the Spanish Agency, you have a product that's more than 10% of reduction of pain, it works. Placebo sometimes is important to take in mind because sometimes people respond to placebo. That means that it's very important to pay patients with high level of pain because sometimes the placebo effect could be very important. And while we see that, was statistically significant, the pain reduction, and we see very clear that, the SPMs reduce pain in this kind of patients. No? That is very important. Another important issue is that they improve quality of life. For us, for our patients, it's very important quality of life because the quality of life I can tell you that there are some papers that quality of life of osteoarthritic patients is the same that cancer patients. The quality of life is very bad. People have pain, suffer pain, and have a lot of problems with disability. They cannot sleep by the night. They have comorbidities, etc., etc., etc. And also we can say, too, that it's a gender disease that affects more a woman than men. We can say for the 10 people, 7 are women. The osteoporosis is between 10 and 8. That means a gender disease, too. That means that to have a product like this, that they can reduce pain and they can improve quality of life, another important issue is that it's a safety product. For osteoarthritis, it's very important, the safety, that at least don't produce any kind of problems. It was published in the New England Journal of Medicine that NSAIDs in the United States, people died, 60,000 people per year. And more or less, there are 140,000 people that they are affected and they are in the hospitals. In Spain, we calculate that more or less there are 2,000 people that die each year by NSAIDs. This is explained every time, but journalists, they don't put it. There are more people that die by NSAID than by traffic in Spain. And this is published, it's not. That means that to have safety, to have a product safety, I think is very important, because don't forget that the patients have osteoarthritis, they have comorbidities. They have hypertension, they have depression, they have anxiety, etc. That means it's very important safety. And of course, reduce the pain. Well, I don't have time to speak about this study, but it's published. You can say that our study is the first time the effect of continuous oral SPMs consumption in adult population of symptomatic NEOA. They reduce pain and improve quality of life of the patients. No? It was not any dropout. That is very important. Dropout, that means that patients, they go out of the study because sometimes the treatment doesn't work or because there are side effects. In this case, any patient take a dropout. That means that it's another secondary endpoint to see that the product works. And was not any adverse events. In this case, we can say that SPMs Lipinova, that is the product that you use in the trial, improved knee resolution and functionality during the 12 weeks of supplementation. Well, that's all. 10 minutes, no?